Thank you, Dr. Spatz. With that, I'd like to present Angelina Drake to speak on behalf of PHI.
Thank you. Good afternoon, everyone. I'm really thrilled to be here with you. And I'll be speaking today about maximizing the role of the home care worker in the delivery of community-based care. And I want to start by looking at home care work itself, looking at the challenges that face its delivery, and the significant challenges facing the workforce that delivers this care, followed by an examination of the models that pose promise around upskilling and care team integration of this workforce as a way to quantify its value and drive those savings back into the needed job quality improvements in this sector. So when we think about home care work, we think about its impact on patients, their ability to remain living in their homes and communities and managing their conditions. Think about its impact on family members who are able to go to their jobs knowing that their loved ones are cared for. But as the population is changing and there's tremendous demand for this type of service, and there are also policies that are rebalancing care into the home and community setting, we have to build a system with a strong and stable home care workforce to support this demand. But we can't do that until we have a system that values home care work and the people who provide it. So there is this common nomenclature that calls home care work unskilled or low skilled. And like Joanne, I really want to challenge that notion. So I'm going to do so building on my own experience. I was a home care worker in my home state of Florida for years. My client, one of them was named Christine. She was in her 80s. Christine had lung disease that required 24-hour oxygen support. She was also in the early stages of dementia. So for me to provide her with quality care, I needed to understand these conditions, how they affected her body systems, and how they would affect her life day to day. And in Christine's case, these conditions would often overlap. So she would forget, for example, to reapply the cannula that connected her nasal passage with the oxygen machine. So I just had to look out for that and remind her to reapply it. I needed to understand her plan of care and the signs and symptoms to look out for that could indicate that her conditions were worsening. So in her case, it was listening to her breathing, understanding what patterns of breathing were normal and what might not be. In her case, she often fell underweight, so it was important for me to track her weight and make sure that she had calorie-dense meals that were available to her and that she would accept during my shifts. And core to the role of a home care worker is supporting clients with the activities of daily living. Christine needed significant support with bathing, toileting, and dressing, and I was fortunate in the sense that she accepted the support that I gave her with these very intimate tasks. Not all patients and clients in these settings do. I had another client named Fred. He was a very outgoing, quick-witted man in his 90s, and he was suffering from chronic leg pain following a fall. And when he would encounter a task that he had previously been able to do independently that now required my support, he could get very frustrated. And sometimes that frustration was taken out on his home care workers. So in these moments, I needed to draw on my communication skills, my self-management skills, and my problem-solving skills to be able to understand what was at the root of his agitation, not take it personally, and give him space to vent, but also know how to redirect the conversation to something more productive for our day. As anyone who's done this work knows, home care requires both physical and emotional strength. There were days where managing a client's mood swings could be as physically and emotionally demanding as the physical stress of moving them for a mobility transfer. So Fred needed help, for example, moving from the hospital bed in his home into his wheelchair or from the wheelchair into the car. And last but not least, I was tasked with ensuring the safety and security of my clients. So in Chris's case, this meant making sure she didn't trip over the wiring of her oxygen machine and there was nothing else in the house that might obstruct her walking. I also needed to make sure that she was in a sterile environment because her immune system was lowered when she was underweight. And for all my clients, knowing that their families understood where they were and that they were safe and secure under my care was critical. So drawing on this experience, it's very clear to me that home care is not low-skill work. It's work that draws on an array of diverse skills that are constantly at interplay. And I would go so far as to say this is middle-skill work. It's not considered middle skill by the systems that govern its training, regulation, and payment, but it's this type of systemic lack of investment and trust in home care work that's helped shape the poor job quality in this field over time. So to recap some of these factors that Joanne mentioned as well, wages are low. They are at or near the poverty level in most settings. It's difficult for workers to pull together full-time schedules. Employers are incentivized to provide part-time wages so they can get out of providing benefits and classify these workers as independent contractors. The training regulations vary among titles and settings, and they are often poorly implemented and enforced. And this leaves workers feeling disrespected by the system, and then they often feel disrespected by the people who they interact with in the healthcare and social service delivery systems. And of course, this work is isolating. It's done in private homes, and there's a real feeling that there's a lack of support. When we look at the home care workforce nationally, we see median annual income of just over $16,000 a year, with wages at $11.52 nationally. This is not a job that's sustainable for individuals and certainly not for families. And this workforce is overwhelmingly women. It is 62% people of color, and a significant proportion, 31%, are immigrants. These factors get to the root of the poor job quality in this field. There is a legacy of discrimination that has shaped job quality. We have put less value on work that is performed in the home, and we have valued home care less because of who has traditionally performed it. So if we want real solutions to strengthen this workforce to care for people with serious illness, we have to understand and try to reconcile these historically discriminatory relationships and put in policies and practices that address the inequity that's based on workers' gender, ethnicity, race, and country of origin. So I want to point here to a quote. This is from Farah. She's a home care worker we know in the Bronx. And her story is fairly common. She really loves what she does. She wants to make an impact on her clients' well-being, but she's not able to support her family working at or above full-time in this industry and considering leaving it. So this is why the problems that face the home care workforce are the problems that face the entire sector of community-based care. These are the problems that face patients who are unable to access quality, consistent home care services. Employers in nearly every area that PHI interacts with are dealing with significant recruitment challenges. A survey that was done in 2018 showed that home care workers have a turnover rate of 82% annually. And workers feel unprepared. There's not a strong system preparing them for the complexity of the work that they're doing today. We are also not optimizing their impact on patient health and well-being because we've disconnected them from the delivery of healthcare and social services. So if we can recognize that home care workers are underutilized and undervalued, we can then develop solutions that affect both of these dimensions of the challenges facing this workforce. We can train home care workers to do more, measure that impact on patient well-being and the cost savings that are associated with it, and use that argument to drive the business case for investing some of that savings back into job quality for this workforce. We have to improve job quality to create the strong and stable workforce that we'll need. So in many settings for home care delivery, you have a home care worker who communicates frequently with the patient and family caregivers. They're uniquely positioned to develop trust, to understand their patient's conditions, their habits, what changes might indicate that something is abnormal in the home. And yet, it's the patient's communication with the traditional care team that is often inconsistent and incomplete that then informs the decisions that are made about treatment and care recommendations. So what's missing here is quality and consistent communication between the home care worker and the traditional care team. And we really need models that see the home care worker as part of that team. And to support that, we need to upskill these workers, providing enhanced training around clinical factors, so understanding the diagnoses that their patients present, how to manage them in the home, and how to support health behaviors, but also training in the social and environmental determinants of health, looking out for stressors, supporting social connection. Even things that are beyond a home care worker's ability to impact herself could be elevated through communication from the home care worker to a care team, something like food insecurity. If that's notified to a social worker, for example, that could support that patient's ability to connect with supports in their community. We also need to provide training in the skills to observe, record, and report this information in order to support an upskilled home care worker's ability to help the patient maintain optimal health in the home setting and critically to reduce avoidable hospital admissions or emergency department visits. So in these settings, we define upskilling as a recognition that the entry-level training that workers have received is insufficient. Upskilling bridges the gap between the training the workers received and the skills that they need to provide quality care to today's home care client. So they cover usually a range of competencies, as you see here: greater clinical knowledge about conditions, these relational skills. Again, this is intensely interpersonal work. Many of the disruptions in care that happen in home care are interpersonal. Understanding the social determinants of health, and then how to observe, record, and report this information. It's important to note that upskilling keeps the home care worker within their existing scope of practice. It's usually not associated with a promotion. And we've established that home care workers are underpaid, so I believe that upskilling does need to be paired with a wage improvement, but it isn't always. And yet, you can prepare a home care worker to observe this information, but if there's nowhere for their information to go, their impact on patient well-being is going to be limited. This is evidenced in quotes from Ricardo. He's another home care worker who, at his agency, has information he wants to report about his patient's well-being, but when he calls his agency, he feels like he's leaving a message. If he gets a follow-up, it happens days later as the message is passed from one agency to another. In that time, he's had to make decisions about his patient's care. Very often, he's bringing them to the emergency department. So we have to pair upskilling with workflow innovations that bring workers' observations to a care team. This is best done when it's through a regular and structured reporting process. There are some models where we have home care workers pick up a phone each shift and they answer a series of yes or no questions about changes in their client's condition. Those questions are all weighted and they're sent to a clinical RN who's able to look at it and provide real-time feedback. But we're always going to need that ability to have free-form communication as well. There's a lot of unpredictability in the home care environment, and to have a home care worker be able to pick up the phone and speak to a care manager or an RN is going to greatly improve their ability to do triage and really understand what the next step of care should be. There are opportunities to introduce new technology for these functions, but we can also achieve this through existing technology. It's difficult to implement new tech in very under-resourced environments, so there's opportunities to look at what communication workflows exist and how we could amend those. There are also opportunities to develop advanced roles for home care workers. That's another critical aspect of their job quality. We can have advanced care models where you have someone serve as a liaison from the home care environment to the care team. So they build trust with the entry-level worker there and then carry their observations to the team. And importantly, we can't just upskill the home care worker. We have to train other members of a care team to value what they have to say, to listen to them, and to respect that their observations about the client are valid. So there have been a range of studies that, demonstrations really, that combine upskilling and care team integration of the home care workforce. They've all varied in their size, scope, and evaluative capacity, but they do suggest promise. So these are the three largest studies that have been conducted that have published their data. They're in California and New York. And you see across these interventions that there are significant improvements in a reduction in emergency department visits and avoidable hospitalizations, as well as improvements in customer or client satisfaction with care. As we build on these and do additional demonstrations, it's really going to be important that we speak to the incentives of the payers in the system. So that means measuring for the clinical outcomes around emergency department visits and hospitalization, things like delays going into a nursing home. Those are associated with costs that payers want to go down. Employers are going to be interested in improving their retention of their workforce, so we need to be reporting on that information as well. And these small pilots should build the momentum for us to generate interest among funders to develop larger pilots. And from there, we can build the evidence base that we're going to need to create real change in this industry and get adoption of these models by state departments of health and large insurers. Policy plays a huge role in the delivery of home care in this country, and upskilling and care team integration are just a piece of the job quality puzzle. We need more money in the system overall and a recognition that if we invest in home care workforce now, we will all save later. There are also opportunities that have been successful at the state level to do wage pass-throughs. So these are targeted specifically at improving workers' wages or pass-throughs through the reimbursement rate through Medicaid, which is the largest payer of home care services, to fund training, because right now the reimbursement rate for home care services does not include training costs. There are also opportunities at the state and federal level to fund this type of innovation that can create the evidence base for this business case. There's a bill on the floor of the House right now that does just that. We also need to improve training standards to emphasize the competencies that are needed to provide care to today's long-term care patient. And there can be state-level recognition for these micro-credentials. If someone's getting upskilling, it needs to be something that's valued across their employment landscape. I've been doing this work for 10 years, building on decades of work done before me, and the moral case for improving wages in this field is not working. The population projection case for improving job quality in this field is also not working. We know there are going to be 4.7 million job openings among home care professions by 2028, and we're nowhere near getting that done. So I believe that if we really want to move the needle here, we need a strong business case for investing in this workforce, but we also need more popular pressure. We need people talking about the role of home care in their lives, how it affects their families when they can't easily access or afford quality care, and that the impact that that has on their families, as well as the impact on workers who are unable to have a sustainable job. So I'm going to leave you here with a quote from Marisol. She's a Care Connection senior aide upskilled through one of our programs. And as she knows, this role should be considered as important and any other in the patient's experience. Thank you.